Hello, my name is Dr. Serena White, and today I'd like to present our audit entitled Documentation of Anaesthetic Discussion During Preoperative Assessment, a retrospective clinical audit at University Hospital Limerick. The Preoperative Assessment Clinic plays a key role in the perioperative journey by supporting shared decision-making, informed consent and continuity of perioperative care. As shown on the left, the University Hospital Limerick Preoperative Assessment Form contains a dedicated section for documenting the proposed anaesthetic technique, together with the risks, benefits and alternatives discussed with the patient. Despite the importance of this documentation, this section had not previously been audited. Our aim was to determine how frequently these four components of the anaesthetic discussion was documented during the preoperative assessment. We performed a retrospective clinical audit within the preoperative assessment clinic. 30 consecutive adult elective surgical patients with completed preoperative assessment forms were included. Data was collected over a single day using a standardised audit tool, with each documentation criterion assessed using a binary yes or no outcome. Our audit standard for each criterion was 100% compliance. The results demonstrated low compliance across all four domains. Documentation of the proposed anaesthetic technique was the highest, occurring in 30%, or 9 out of 30 assessments. Documentation of risks were identified in 26.7%, benefits in 16.7%, and alternatives in only 10% of assessments. Most importantly, only 2 out of 30 records, representing 6.7%, documented all four required elements of the anaesthetic discussion. These findings demonstrate that the current audit standard was not achieved. In summary, complete documentation of all four elements occurred in only 6.7% of assessments, meaning the audit standard was not achieved. It is important to recognise that this was a documentation audit. We did not assess whether these discussions took place, only whether they were documented. In addition, the final anaesthetic technique is confirmed by the consultant anaesthetist on the day of surgery. Nevertheless, documenting the anaesthetic discussion remains important. It supports communication within the perioperative team, provides a record of the information discussed with the patient, and promotes informed consent. Based on these findings, we recommend focused education on documentation of the anaesthetic discussion, reinforcement of the importance of documenting any discussions had, and re-audit following implementation. Our key message is that improving documentation of the anaesthetic discussion represents a simple and achievable opportunity to strengthen informed consent and patient-centred perioperative care. Thank you.